So in this section, we'll look at the internal and external anatomy of the heart. Some of this will relate back to the flow of blood that we discussed earlier. Some of these items are just housekeeping, naming basic structures of the heart. And we also get into the coronary circulation that provides blood to the heart muscle and drains it away. So here are a whole bunch of structures of the internal anatomy of the heart. I'm going to go to another slide where I pulled out some of these. I just want to focus on a few portions of this movement of blood that we haven't really discussed yet or went through quickly. One of those would be that the aorta has several different portions. So when blood comes out of the left ventricle and goes through the aortic semilunar valve, which you just see a little tiny bit of here, this part of the aorta superior to that valve is called the ascending aorta. And then the blood will travel through the aortic arch and then duck down behind the heart, which is now called the descending aorta. Now, in fact, the descending aorta, when it's in the thoracic cavity, is also referred to as the thoracic aorta. And when the descending aorta continues to drop down into the abdomen, it's often referred to as the abdominal aorta. In fact, maybe more often, it's called the thoracic aorta and abdominal aorta. But you want to know these different names. The other thing we can note here is that the aortic arch has three branches off it. This first branch is called the brachiocephalic trunk. Brachial means arm, cephalic means head. So, this trunk, and remember trunks, just like on a tree trunk, have branches. So anytime you see trunk, you should be thinking there's going to be some branches coming. The brachiocephalic trunk is going to branch. One portion is going to go up to the head, cephalic. One portion will go out to the arm, brachial. On the other side of the aortic arch, there is no trunk. There is no split. You just have two branches there. One is going to go up to the head. One is going to go off to the arm. So you end up eventually with 1, 2, 3, 4 vessels. It's not a mirror image on the left and the right side. So brachiocephalic trunk on the right-hand side. On the left side of the aortic arch, the vessel that goes up to the head is called the left common carotid artery. So the carotid artery is something you can take a pulse on. The other is the left subclavian artery. Subclavian means under the clavicle. So somewhere down around underneath this clavicle is my left subclavian artery. The other structure we can see here related to the movement of blood is this, the opening of the coronary sinus. So we haven't talked in detail about the coronaries yet, but we will shortly. But basically, the heart needs blood too. It's a tissue. It's got a lot of work to do, actually, constant work. So you want to provide it with some blood. After the blood gets used, well, what do you do with used oxygen poor blood? You send it back to the right atrium. So in addition to the blood coming down from the superior vena cava and the blood coming up from the inferior vena cava, you also have blood coming in from the opening of the coronary sinus. So 3 different places, clerk, 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 all filling up the right atrium with oxygen poor blood. Now let's look at some of the structures of the heart that don't have to do with moving blood around. So some of these are just housekeeping, right? For example, here's my left atrium. Here's my right atrium. In between, it's kind of hidden, but there is a wall that separates those two chambers. So it's the interatrial septum. It just literally means the wall in between the atria. Ventricles have a wall in between them too. We're just going to give it the same name, interventricular septum, the wall in between the ventricles. Cool. Next, lining the ventricles are all these bridges or branches of just meat. All these right here, all lining the ventricular wall. Those bridges or branches of meat are called trabeculae carnii. Trabeculae carnii. If you want to learn to speak Latin, very common. But if you want to be able to say this stuff properly, focus on these E's, right? So when you see trabeculae, it has one E. So say the E, trabeculae. Carnii has two E's, 1, 2. So you say both quickly, not carnii, but trabeculae carnii. So this means the bridge-like or branch-like meat, because carne is like carne asada, is meat. So trabeculae carnii. The atrial walls also have some muscle called the pectinate muscles. Can't quite make it out, but it's here on a portion of the atria. And pectinate refers to comb-like. So they're much thinner and kind of parallel fibers on the wall of the atria called the pectinate muscles. Okay, now let's talk about these valves. The AV valves, so here's the tricuspid valve and the bicuspid valve, they have some equipment that the semilunar valves don't have. Papillary muscles, right? And papilla means nipple shaped. So this little nipple shaped structure here, this one here, here's another one here. Those are all papillary muscles. They're attached to chordae tendineae. Chordae tendineae. Chordae tendineae. So those are heartstrings or tendinous cords for a literal translation. So here's what we got going on. Heartstrings attached to these little muscles only on the AV valves. And we'll talk about why that is on the next slide. Last couple things here. Conus arteriosus, housekeeping. It's just this cone-shaped portion of the pulmonary trunk where things start to kind of narrow in to the pulmonary semilunar valve. The cone-shaped part of this artery. And last are fetal remnants. Fetal remnants. Fetal remnants are pretty cool. Remember that as a fetus, you have the placenta there to facilitate gas exchange. So you're not taking any oxygen into the lungs, and you're definitely not sending any blood to the lungs. Remember, the right side of the heart is all about the lungs, but we basically want to bypass the lungs. So the fetal remnants are the remainders, the remnants, the leftover structures that used to help us bypass the lungs. One of those is, what should we do first? Let's do fossa ovalis first. As a fetus, you have a hole right here in your heart. This hole is called foramen ovale, meaning the oval-shaped hole. So as blood returns to your right atrium as a fetus, the blood is actually going to pour into this hole, and it's just going to pop out over in your left atrium. Because this blood is coming back from the placenta, it's good to go. It doesn't need to go to the lungs. You want to skip the lungs. They're just like shriveled up little gross limp hangy things, yeah? You want that blood to go out to the body. So the blood goes into this hole and passes over to the other side of the heart. When you're born and you take your first breath, there are all these pressure changes that happen when the air enters the lungs, and that pressure changes causes this little flap to close up over the hole. And super quickly, that flap will just cement itself into place and just leave a little oval-shaped fossa. Remember, that means like kind of a dished out shape. Now, it sounds pretty magical, and it is, except that it doesn't always seal up quite right. So that's one of these common congenital birth defects, is to have this closure not completely seal up. But when it works, it happens very immediately, very well, seals up, and all we have left is a fossa ovalis. The second is the ligamentum arteriosum. This means it's a ligament-like artery. This structure here. So here's the thing. When you're a fetus and the blood comes back into here and it goes into the foramen ovale, not all the blood is actually going to go in that hole. Some blood will make it down into the right ventricle and fill up the right ventricle partially. And the heart will beat and that blood will start to head to the lungs. We don't want it to, but it's headed that way, it's headed that way, it's headed that way. But as a fetus, rather than continue towards the lungs, the blood will enter the ductus arteriosus, an arterial duct, an opening. And the blood will jump out of the pulmonary trunk and into the aorta and go off to, deliver that blood out to the body. So it's a second way to bypass the lungs. When you're born, this goes away. It becomes no longer a duct. It becomes something more akin to a ligament, just some old connective tissue. And doesn't serve any purpose anymore, although it's probably worth noting just quickly that in a car wreck, the leading cause of death is TBI, is traumatic brain injury, but the second biggest cause of death is basically the heart swings forward after that sudden impact, right? The car stops, your body stops, but some of your organs keep moving. So your brain smacks the front of your skull, the heart swings forward, and this little ligament can rip a hole right here and cause an aortic aneurysm. So the blood starts to pour out of the aorta. This is kind of the case where people will be up and walking around after a car accident and suddenly just drop. And that's because the blood is pouring out of the aorta, not making it out to the brain or the body. So it's pretty sad. It's just such a little thing, just one little fetal remnant can have such a big impact in medicine. Okay, so let's take a quick moment to talk a little bit more about the valves. I think of the valves kind of as like kites and also kind of like parachuting, and I'll tell you why. The thing about these valves is, remember that they have these heartstrings called chordae tendineae, and these muscles called papillary muscles. So in this picture, pretend that this lady's biceps are the papillary muscles, and then the strings she's holding on to are the chordae tendineae. So what happens is when the left ventricle contracts, it's going to be pushing blood up. And you know where the blood would like to go is just back into the left atrium. I mean, think about it otherwise. The blood would have to climb up the ascending aorta. It doesn't want to do that. It's going to take the easier route. It wants to go back into the left atrium. We can't let that happen. We don't want blood to go backwards where it came. So instead what happens is as the ventricle contracts, the blood is going to smack into this valve and cause it to close. So far, so good. But then the blood will keep pushing and push more and more pressure against this valve. And what it wants is valvular prolapse. What it wants is that valve to pop open and let the blood go back into the left atrium. It's an easier journey than climbing up the ascending aorta. So how do we make sure that as the valve gets pushed closed, it does not prolapse? It doesn't blow back open the way it came. And the answer is, of course, papillary muscles, chordae tendineae. Think of the kite. The kite is flying in the sky, and the wind is pushing it. The wind wants to blow the kite out into outer space. But you tense up your biceps, and you hold on to that string, and the kite gets pushed up into the air, and then you stop it. And you hold tight, and you hold tight, and you hold tight. And the wind is pushing and pushing on the kite, but you don't let it go any farther. You don't let it go any higher. You don't let it go into outer space. That's how papillary muscles and chordae tendineae work. The blood hits the valve, causes it to close, but then they contract, those papillary muscles contract. They're not pulling down. You don't want to pull the valve open. The goal here is make sure the valve doesn't prolapse. Hold it just perfectly closed. Don't let the blood push the valve open. You make that blood climb the ascending aorta. So, same thing I should say. On the other side of the heart, when the right ventricle contracts, the blood will want to cause valvular prolapse, cause the valve to blow open and return to where it came from, but we won't let it. Papillary muscles contract, chordae tendineae are attached to the valves, and the blood must travel up, 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 up the pulmonary trunk and out to the lungs. So that's how these valves and associated structures are like kites. The reason they're like parachutes gets into heart sounds. And I won't talk much detail about this because you'll do it in physiology. But basically, these heart sounds, this lub and dub sound, well, lub is what happens when the left ventricle and right ventricle contract and they hit the valve and cause it to close. Dub, or sometimes we say dup, dub or dup is when the semilunar valves close. Well, why do they close? Well, remember that blood is getting pushed up, 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 up the ascending aorta as the ventricle contracts, and it's getting pushed up, up, up the pulmonary trunk as the other ventricle contracts. And eventually, the ventricles, they finish their contraction. They've run out of steam, and the blood starts to just fall back with gravity. And then it's going to hit the semilunar valves, dub, and it's going to smack them closed. Semilunar valves don't need a bunch of equipment. They don't need papillary muscles and chordae tendineae. All they have to deal with is like a little bit of blood coming down with the weight of the acceleration of gravity. There's no pump pushing on that blood. It's just gravity pulling the blood down. So they're just very simple little valves. Only the AV valves have all that extra equipment because they have to deal with the ventricles and the strength of those contractions. So lub and dub is the blood hitting these valves, either from below, smacking them closed, or coming down right at the end of the contraction and smacking against these semilunar valves. The reason it's like a parachute is that, well, valves and parachute material are very thin, right? They don't really make noise. You know, if you zhush a parachute around, it's not going to make much noise. These valves are super tiny and thin and light. They don't smack closed. Heart sounds are really the reverberation of the blood slamming against the valves. So boom, that lub and dup is when the blood hits and boom, reverberates the valves. It's not technically the valves closing, but it's close enough. Okay, couple more quick notes. If you want to listen to valves, you use auscultation. Grab a stethoscope. You can find how to do this online. There's 4 specific places that you'll listen to hear the different valves. And I always laugh at this. I look like maybe this guy is like flexing his abs or something, and she's like, "Please don't do that, sir." And you may hear perhaps heart murmurs, some leaky old valves, like old Granny Porter had here, you know, taking me off to church back when I had my hair dyed red. And Granny, valve problems, got some pig valves put into her heart, going strong, 94 years old. Go Granny. She had some blood backflowing into the atria after the valves closed. In her case, not due to a congenital defect or infection, but stenosis, the valves getting old and kind of stiff. So those pig valves are holding strong. Okay, we'll finish with a little bit of external anatomy and the coronary circulation. So looking at the outside of the heart, a few things you can see are auricles. Remember, this is an auricle. So hearts have ears too. The auricles are the heart. So this little bluish thing here, here's on the other side, here's another auricle. You'll also hear these referred to as atrial appendages. They're just like little extra ear cups on top of the atria. Let them hold a little more blood. You'll have sulci, kind of grooves in the heart, but typically you won't see them because, as shown in the image, they're filled with fat. So fat in the coronary sulcus, fat in the anterior interventricular sulcus, and fat in the posterior interventricular sulcus. The reason they're filled with fat is because you have some very important blood vessels protected inside that fat, and those are your coronary vessels. One of which is the coronary sinus, which we already talked about. That is where the blood drains back into the right atrium from the heart. We'll see that here too. So last topic is, how does the blood go to the heart muscle, to the myocardium, and return? So there's a few major branches here. Let's see. We have first the left coronary artery. Left coronary artery here. And it's going to branch very quickly. It's a very short little artery that will branch into the anterior interventricular and circumflex arteries. So circumflex here, anterior interventricular artery here. There's also a right coronary artery on this side, which will branch into the marginal artery and posterior interventricular here and here. And if it seemed like I was confused, it's partly because I usually do these in a different order, and I have a little mnemonic device for that. It's not the best, but I remember it pretty well. It's real men love cats, and I've got one. Real men love cats, and I've got one. So I always start with the right coronary artery, real, and then men, marginal artery, real men, love cats. So then next I do the left coronary artery, love, and the circumflex artery, cats. Real men love cats. And anterior, I've, interventricular artery, got one. And I don't know about got one, but then you have the posterior interventricular artery to finish with. I don't love cats, and I don't got one, but I just came up with that one day, and it stuck in my head. And then that blood will have to return to the heart after it has nourished the myocardium. It will do that through the great cardiac vein, the middle cardiac vein, and the small cardiac vein. I don't have a mnemonic device for that, but I'm sure you can come up with one if you would like. So, for our final portion of the heart, we will talk about the cardiac conduction system, this electrical system that runs through the heart. It gets into these nodes and pacemakers. It's very interesting stuff. And we'll finish with the cardiac cycle.